Precocious puberty in girls. In girls, precocious puberty is defined as development of secondary sexual characteristics before the age of 8 years. The overall incidence of sexual precocity is estimated to be 1 in 5,000 to 1 in 10,000, with the male to female ratio of 10 to 1. Like, if 10 girls are affected by this precocious puberty, then one boy will also have precocious puberty. Just remember one difference, that in boys, if they develop secondary sexual characteristics before the age of 9 years. For boys, the age is 9 years. Okay. So just remember this point. For boys, it is 9 years because all of these are EMC. All of these are questions. So what are the consequences if it happens? Consequences are physical, psychological. Puberty is a complex developmental process that begins in late childhood, and it is characterized by maturation of the hypothalamic pituitary gonadal axis, the appearance of secondary sexual characteristics, acceleration of growth, and ultimately the capacity for fertility. So all of these four things, if you are seeing in a child, it means that the girl has precocious puberty. These are the part of puberty, and if they occur early, then we call them precocious puberty. Puberty is described as consonant if it follows the normal sequence of pubertal changes, or disconsonant if it is abnormal. It doesn't follow the sequence of normal pubertal changes. So in puberty there can be physical changes, and this is the definition. If you are seeing the physical changes in a child, then you will say we are seeing puberty. Adolescence, it means that there are psychological and social changes. This is also SPA, what is puberty and what is adolescence. So just remember these definitions. The physiology of normal puberty. The hypothalamic pituitary gonadal axis starts functioning during fetal life, remains active for several months after birth, and is then quiescent till puberty. Precise mechanism of puberty is unknown. An onset of puberty is heralded by an increase in the amount of pulsatile gonadotropin releasing hormone, which is secreted by the hypothalamus. This GnRH release leads to an increase in the release of the gonadotropins, which are luteinizing hormone and the follicle stimulating hormone from the anterior pituitary gland. Initially, these changes they occur during sleep. As the puberty advances, it progresses to 24-hour secretion. Follicle stimulating hormone stimulates the development of the ovarian follicles, which in turn produce estrogen. After ovulation, luteinizing hormone stimulates the corpus luteum to secrete progesterone. Adrenarche is the onset of androgen-dependent signs of puberty, like development of pubic and axillary hair, greasy hair and skin, acne, and adult body odor as a result of adrenocortical activity. Next stage is gonadarche. It means there is gonadal activation. It begins by 6 to 8 years of age and continues until late puberty. There are clinical stages of the puberty, like the Tanner stages. They are used to describe the sequence of development of the breasts and pubic hair, and it begins with the stage 1, that is the prepubertal, and concluding with stage 5, that is the adult stage. In addition, axillary hair is graded from stage 1 to stage 3. Stage 1 is prepubertal and the stage 3 is full adult development. So these are Tanner stages, and you can see here that in the stage 1 there is no change, just the nipple and the breast are there. In stage 2,
Victoria, I didn't.
rating the breast development, we start from stage 1 and we go to stage 5. Okay, so what happens, like here is just there is like Nothing. The breast is not developed. It is only present there as flat nipple and the breast. And then in the stage 2, it develops a bit, like the fat accumulates here. These changes begin by the 6 to 8 years of life, and then slight changes they can occur. Like at the time of puberty, they will have like something like this, or can be something like this, depending upon their estrogen content, like that. Okay, and then they will undergo different changes, and then there will be separation of this. Here will be separation of the areola and the rest of the breast, and here you will have the adult breast. Similarly, if you are staging with the help of like this Turner syndrome, it has two components: breast development and the pubic and axillary pubic hair. So in the stage 1, no pubic hair, like that. Okay, and then no pubic hair, and then gradually, like this thin hair, they appear on the vulva. Then they start spreading on the whole of this vulva, and here they spread, cover all of the vulva, and they become darker in color. And then in stage 5, you can see that they have covered the vulva, and now they are spreading to the thighs also. So that is the adult stage, like that. Okay, so these are 5 stages. So if they ask you how do we assess them, we assess them by Tanner staging, like that. Okay, that is the point. So like I told you that the normal puberty, that what are the clinical stages? Tanner stages, they are used to describe the sequence of development of the breast and the pubic hair, beginning with stage 1, that is pubertal, and concluding with the stage 5, that is adult. In addition, axillary hair, remember this difference. Axillary hair, like the Tanner stage, we are taking 5 stages. But axillary hair, that is also stage, and that is stage from 1 to 3. That is the thing. And remember that everywhere in the body, the hair growth is under which hormone? We talked about it in PCOS. Androgens,
Yes.
okay? Androgens. It is under the effect of androgens, like that. That is the point. That is the point, okay? So don't worry about it. These things are simple and easy to get the marks here. Okay, so that is the point. So now the timing of puberty. Okay, normal puberty, it commences from approximately 10 years onwards, and usually it lasts 3 to 4 years, with passage from one stage to another one approximately 1 year. In girls, breast budding or thalarch, that is the Tanner stage 2 breast budding. It is
Timing
usually,
of puberty for
yeah,
the boy or
yeah,
for the girl?
girls. This topic is all about girls. Okay,
From
because
10 years to 12. Yes.
so the timing of puberty, the normal puberty, it commences from approximately 10 years onwards and usually lasts 3 to 4 years, with passage from one stage to another approximately every year. In girls, the breast budding or thalarch, that is the Tanner stage 2 breast budding, that is usually the first sign of puberty. This is not about growth. This is that the puberty is setting in. This is followed by the development of the pubic hair, which is pubarch, then axillary hair. Menarche usually occurs within 2 to 3 years of thalarch, and the median age of menarche is around 13 years. Different people, different books saying different things. This 13 years, that is agreed upon by the ACOG and the RCUG. And the other books, they say that it is 12 years and 10 months, like that. So the classification of precocious puberty. As you know, it can be central, like which is true, or due to gonadotropins. So this is dependent upon gonadotropins. Like the hypothalamus is producing more and more gonadotropin, and the girl is maturing because these gonadotropins, which are coming from the gonadotropin releasing hormone, which is coming from the hypothalamus, it will stimulate the anterior pituitary to produce more FSH and LH. Okay. Then there can be peripheral or the pseudo or gonadotropin independent. No role of the gonadotropins here in the peripheral. Then there can be a third variant which is isolated. Okay, so there can be like precocious thalarch, pubarch, or menarche. You see, adrenarche is not considered here because adrenarche and the growth spurt, they will occur before pubertal changes they start. What are causes of premature sexual development in girls? So we have different causes for central precocious puberty and peripheral precocious puberty. Most common cause is idiopathic. We have no idea how it started, why it has started. Central nervous system pathology or lesion, hypothalamic hamartoma, then different tumors like astrocytoma, glioma, craniopharyngioma, pituitary adenoma, congenital disorders like hydrocephalus, myelomeningocele, then arachnoid cyst, then in the acquired lesions like the conditions like the central nervous system irradiation, post-head trauma, then post-infection, encephalitis, meningitis, and if somebody has received chemotherapy, then it may be secondary to peripheral precocious puberty. Because if the peripheral organs are mature, they will also like cause changes in the central system also. Causes of peripheral precocious puberty, the most common one, ovarian causes. Like estrogen secreting tumors like the granulosa cell tumor or functional ovarian cyst. Then androgen secreting tumors like Sertoli Leydig cell tumor, adenoblastoma, which can be like co-transsexual, and then the adrenal causes. We know that I think we read before also in hirsutism that Sertoli Leydig cell tumor, that is number one cause of hirsutism and virilization, because it is just going to pour androgens, and this Sertoli Leydig cell tumor, and female she can end up having a long hair also like that. That is one thing. So then adrenal causes like congenital adrenal hyperplasia, then Cushing syndrome and neoplasm. These neoplasms they can secrete estrogen or androgen, and these can be adenomas or these can be carcinomas. Exogenous sex hormones like someone is taking oral contraceptives, applying skin creams, using anabolic steroids like for bodybuilding, then uh, or due to some other cause, and then McCune-Albright syndrome and severe long-standing hypothyroidism is an important cause of precocious puberty. So there can be like different variants of normal pubertal development. Like the changes are normal, but they are occurring and there can be some variety. Like there can be premature thalarch, or there can be like the thalarch and the thalarch variants can be there. Then isolated premature menarche can be there. Then premature pubarch, adrenarche, anything can be there. They don't ask you about the different varieties. They just ask you about the sequence of events and what exactly happens in each stage. So we have how do we evaluate the child with premature sexual development? History is very important. Age of onset, sequence and progression of pubertal changes, family history like timing of onset of puberty in mother and the siblings, because in families a general pattern is followed, neurological symptoms, exogenous sex steroid exposure in food, drugs, or cosmetics like steroid creams, estrogens, anabolic steroids, social history like history of adoption of child or child sexual abuse, clinical examination, so height and weight measurement plotted using the specific growth charts, body mass index, pubertal tenor staging, neurological examination, examination of eyes including visual fields and fundoscopy, skin lesions like there can be cafe au lait spots like the dark pigmentation on the skin, abdominal examination, examination of external genitalia, signs of virilization like masculine changes like clitoromegaly, enlargement of the clitoris, deepening of the voice, and hirsutism. After general investigations, you need to do biochemical specific investigations like serum LH and FSH levels. This is the baseline. Gonadotropin releasing hormone stimulation test. Here we are going to see the LH and the FSH levels. Estradiol testosterone levels. Adrenal steroids like 17-hydroxyprogesterone, dihydroepiandrosterone sulfate, and androstenedione. So all of these are raised in congenital adrenal hyperplasia as well as in adrenal tumors. Adrenocorticotropic hormone stimulation test. This is used to identify steroid synthesis defects in the congenital adrenal hyperplasia. We can test pre-thyroxine and the thyroid stimulating hormone. Serum prolactin levels, they may be raised in chronic hypothyroidism. McCune-Albright syndrome or prolactinomas, or point towards pituitary stalk compression. So if there is this pituitary stalk compression, or like they give you the question that it has been cut, what will happen? You should remember gonadotropin releasing hormone. It inhibits prolactin, okay? And GnRH is coming from the hypothalamus. So if there is injury or compression, then GnRH is not coming. So no effect on the pituitary gland, and pituitary gland will continue to produce more and more prolactin. And if there is high level of prolactin, it will cause amenorrhea and other changes, okay? So then you should remember that McCune-Albright syndrome, it can cause precocious puberty or prolactinomas, or if there is something like compression of the pituitary stalk, again there can be pubertal changes. We need to check the urinary steroid profile to identify and quantify excess adrenal androgens. If she is having congenital adrenal hyperplasia, then you know that she will have high level of 17 hydroxyprogesterone in her urine. Further investigations involve imaging. So here we are doing left wrist x-ray for the bone age. In the exam they will tell you that we should do right wrist x-ray. Your answer is left wrist x-ray should be done. Then cranial MRI and the CT. Then CT of the adrenal glands, because we want to look for adrenal masses. Pelvic ultrasound, we need to see the size and shape of the uterus, endometrial thickness, and ovarian morphology. In a young child, you don't expect to see endometrial thickening, but this here in precocious puberty, you are dealing with a child who has high level of FSH and LH, and then if FSH is high, so it means that she is producing estrogen, so there can be endometrial thickness increase. That's why we need to see it just like the adult. After that, you should do skeletal survey and the bone scan, because it will give you info if she has this McCune-Albright syndrome. And the central precocious puberty, it results from the premature activation of the hypothalamic pituitary gonadal axis. And in the peripheral precocious puberty, the hypothalamic pituitary gonadal axis is not involved. Precocious puberty, it can be further categorized as either isosexual. Isosexual means that the secondary sexual characteristics are appearing and they are appropriate for the child's sex, like what is the sequence and how they are appearing. Or it can be, precocious puberty can be heterosexual or the co-transsexual. It means that the secondary sexual characteristics, they are contrary to the phenotype of the sex. It means like there is virilization in the girls, or there are female-like changes in the male, like the penises are growing, the testes they are not increasing the volume, so it can be different.
Yes.
Evaluation of the child with premature sexual development. Who should do this? So OB people, you need to involve pediatric endocrinologists for evaluation and management. An assessment should include a detailed history, thorough examination, and investigations. And it should be indicated by the clinical assessment that she is having this central or the peripheral. The central precocious puberty is characterized by a premature activation of the hypothalamic pituitary gonadal axis, and it follows a clinical course which is similar to the normal puberty, that is consonant. That changes will occur in the same sequence as you expect in the normal child. The majority, like 74% of the girls, they will have idiopathic central precocious puberty, but it can be secondary to an underlying disorder also. Conditions which are known to be associated, like I mentioned before. So although a child, it may initially present like the causes of central and the precocious I mentioned before, okay? Just remember those causes well, because they like to ask you like 2 or 3 questions on a single topic. that is precocious puberty. Okay, so although a child may initially present with tall stature, accelerated bone maturation, and premature epiphyseal fusion, and it may cause growth to cease early and compromise spinal height. Initially, too much growth and everything is there. But when you will see that what is the final outcome, like if you will compare to the other children, then these people who had precocious puberty, they are going to be short, okay, overall. So then psychological problems, they may arise due to pubertal levels of the sex steroids, resulting in adolescent behavior. And psychological problems, they can also arise from the altered self-image or the child being expected to behave appropriately to their physical maturity, not according to their chronological age. You know, the 8-year-old girl, but she has developed the changes, so everyone is expecting that she will behave like an adult female. So, which she cannot, like, because she's only 8. So, it results in conflicts in the family, and the children they like face physical abuse or psychological abuse because they are not living up to the expectations of the others. Girls are at increased risk of sexual abuse and early pregnancy. What investigations should be done? The bone age is advanced, like this is we are talking about the central precocious puberty. They like to ask you that what will happen in the bone age and the scan age. So the bone age is at and the chronological age. The bone age is advanced often by more than 2 years. Like she is 8, but her bone age, like you are taking the X-ray of the left wrist, so it will tell you that this child is 10-year-old. Okay. A uterine volume of more than 2 milliliter or length more than 34 millimeter, and she can have a pear-shaped uterus and endometrial thickening on pelvic ultrasound. These are associated with progressive central precocious puberty. Baseline serum gonadotropins, they must be raised, may be raised. GnRH hormone, luteinizing releasing hormone stimulation test, that is gold standard, which is performed by measuring FSH and LH levels sequentially after administering a gonadotropin releasing hormone bolus. So you will give GnRH bolus, analog bolus to the child, and after that you will measure the FSH and LH level. In healthy pubertal children, the LH response level, it must be higher than the FSH, like that. In a healthy pubertal child, LH will be um, more than the FSH. So this ratio is going to be more than 1. So this is what's called that the androgen um, challenge test, like that. Okay, LHRH stimulation test. You will give them GnRH analogs, and after that you will see that what is the raise in the FSH and the LH. So LH response will be higher than the FSH. So LH to FSH ratio will be more than 1. This is diagnostic of central precocious puberty. MRI of the brain or the CT of if the MRI is not available, that is advised in all girls with progressive central precocious puberty to exclude a central nervous system lesion. What is the treatment of central precocious puberty? So in the majority, no apparent cause is found, although it is important to look for evidence of any underlying disorder. The goal of the treatment is to halt or cause regression of the secondary sexual characteristics, arrest the growth of secondary sexual characteristics, prevent early menarche, and retard skeletal maturation and improve final height, avoid psychological and behavioral sequelae. Gonadotropin releasing hormone analogs, they are the mainstay of the treatment, and continuous stimulation of the pituitary gland, it results in a short period of pubertal stimulation which is followed by down regulation of the gonadotropin releasing hormone receptors, pituitary desensitization, and reduced gonadotropin synthesis. GnRH analogs, they are available as rapid acting or the long term depot preparations, and the long acting preparations, they are available and they include leuprolene and triptorelin and gozerlin. They are given subcutaneously or they can be given intramuscularly also. So all these, they are not going to ask about the drugs, but you should know that they can be used the GnRH analogs we are going to use because you want to arrest the growth of these changes like that, development of these changes, okay? So these drugs, how often we are giving them? Every 3 to 4 weeks, or they can be given as a long acting depot at 10 to 12 weekly intervals. So you will have to give like 5 or 6 times the 4 or 5 times in a year. So short-acting intranasal preparations such as nephralin, they are available for daily administration, and these are less efficient, and there are significant difficulties with compliance. So much better to give, every 4 weeks, or you can give at like 10 to 12 week intervals, okay? Because as a depot preparation, because the child cannot have good compliance, additional headache and stress for the girl and the parents. Gonadotropin releasing hormone treatment, it doesn't improve final height of the girls beyond 8 years of life. So GnRH has no effect, okay, on the final height. It is important not to underestimate the psychological and social effects of beginning puberty too early, and both for the child and her family, because of the risk of abuse. That is a significant risk. And then the child can have like psychological manifestations like the irritation, depression, like they are not responding properly because they cannot see themselves like this, and the behavior is not mature. Only the body is maturing, but the behavior is immature. Monitoring of response to the treatment, because whenever you are giving some treatment, you should know that is it effective for this person or not. So a suppressed LH response to gonadotropin-releasing hormone testing indicates that the therapy is having the desired effects and can be used to evaluate treatment efficacy. Treatment with gonadotropin-releasing hormone analog is
Sorry.
usually
Now,
stopped
now on the short acting.
12 weeks. Okay, so
Mm.
once you have given them gonadotropin-releasing hormones, then you are going to monitor the response. A suppressed LH response to gonadotropin-releasing hormone testing, it indicates that the therapy is having the desired effect, and it can be used to evaluate treatment efficacy. Treatment with gonadotropin-releasing hormone analog is usually stopped when it is time for normal puberty to begin. The decision to discontinue treatment, it should be taken jointly by the endocrinologist, the child, and the parents. Pubertal manifestations, they generally reappear within months of gonadotropin-releasing hormone analog treatment being stopped. Because the moment you will stop, the girl will again start showing the signs of pubertal development. Like you will see that the breast size is increasing or something is occurring. So that's why the treatment is continued, like within a mean time to menarche of the 16 months. So like you have stopped the treatment today, so maybe in next 16 months she will have these pubertal changes, like the menarche will start. That is the point. Okay, so so that's why the child endocrinologist has to decide. So what are the adverse effects of gonadotropin releasing hormone treatment? The child can have headaches, hot flushes, mood swings, injection site reactions such as rashing, bruising, and sterile abscess formation. Long-term use, it may be linked to the development of polycystic ovary syndrome, that is long-term. These children who are getting these treatments, GnRH analogs, they can develop PCOS in the future also. Adult bone mineral density, it appears not to be adversely affected by the childhood gonadotropin-releasing hormone therapy. That's all you need to know about the central precocious puberty. Now, peripheral precocious puberty. This is also known as gonadotropin independence precocious puberty or precocious pseudopuberty, and this is relatively uncommon in girls. It results from the secretion of sex steroids, which is autonomous and independent of the hypothalamic pituitary function. Clinical features, they are dependent upon the etiology, but often include rapid growth, advanced bone age, pubic axillary hair, and clitoromegaly. Causes are multiple. Ovarian causes, like ovarian tumors, they can be either feminizing or masculinizing. Granulosa cell tumor, which may present with premature breast development, abdominal pain, or vaginal bleeding because it is going to produce plenty of estrogen. Then there can be androgen producing ovarian tumors, for example, Sertoli Leydig cell tumor, adenoblastoma, and they present with progressive virilization and they cause co-transsexual precocious puberty rarely. Adrenal causes like the congenital adrenal hyperplasia and adrenal tumors, they may cause premature sexual development. Girls with the classic congenital adrenal hyperplasia, of which the most common form is 21 hydroxylase deficiency, they usually present in the neonatal period with ambiguous genitalia and salt losing crisis. Adrenal tumors, they can produce androgens as well as cortisol, and there may therefore be iso or the heterosexual precocious puberty, and in addition to the clinical signs of Cushing syndrome. McCune-Albright syndrome, this activating mutation of the GNAS1 gene. And this condition, McCune-Albright syndrome, is characterized by polyostotic fibrous dysplasia, that means abnormal bone cysts, cafe spots which are hyperpigmented macules with irregular edges, and peripheral precocious puberty. Premature menarche, it may be the first clinical sign in these girls. Investigations, the bone age is usually advanced except in the hypothyroidism. Baseline FSH and LH concentrations, they are in the pre-pubertal range. We said that peripheral one is independent of the gonadotropin releasing hormone which is coming from the hypothalamus. So these girls are going to have normal levels of the FSH and LH according to their age. Gonadotropin releasing hormone or luteinizing hormone releasing hormone testing levels, they are relatively flat gonadotropin response, so no increase like you will give them LH RH, and then you will test the FSH and LH level and they will be normal, they will not increase. Serum estradiol, it may, you are going to see very high levels which may be associated with ovarian cysts or the tumors. If adrenal cause is suspected, measurement of the serum 17-hydroxyprogesterone and other androgens like the testosterone, androstenedione, and dehydroepiandrosterone and dehydroepiandrosterone sulfate is indicated. Serum 17-hydroxyprogesterone levels, they are elevated in adrenal enzymatic defects like 21-hydroxylase deficiency or classic congenital adrenal hyperplasia. And they may be elevated also if the girl has adrenal tumors. Urinary steroid profile and adrenocorticotropic hormone stimulation tests, they are useful in identifying adrenal steroid synthesis defects. How do we treat the peripheral precocious puberty? We should see the etiology and then we should offer the treatment, because we said that this the peripheral precocious puberty can be due to different reasons. If there is hypothyroidism, then we need, like, you are going to see high level of TSH and low level of the free T4, so we need to replace thyroxine. Exogenous source of steroids, the treatment is to discontinue the source of the sex steroids. If she has classic form of congenital adrenal hyperplasia, then we should provide glucocorticoid treatment with usually with mineralocorticoid replacement. Mostly we are giving them hydrocortisone and fluorocortisone. I have seen this one also in the questions, that how you are going to treat it, because it is causing precocious puberty. So you are going to give hydrocortisone and fluorocortisone. If there is non-classical congenital adrenal hyperplasia, it means that it is developed it was not present at the time of birth, but later it has developed. Okay, so then we need to do the treatment with the hydrocortisone alone to allow attainment of the normal adult height. If there are adrenal and the ovarian tumors, then surgical treatment or chemotherapy or radiotherapy depending upon the tumor. And also If there are like chronic hypothyroidism, like because of the enhanced thyrotropin releasing hormone secretion stimulating prolactin, then pelvic ultrasound and the adrenal CT, they should also be done to look for gonadal or the adrenal tumors. In girls with McCune-Albright syndrome, a skeletal survey and the bone scan, it may identify the characteristic boning abnormalities of the polyostotic fibrous dysplasia, and in this case, the suppression of the gonadal steroidogenesis with aromatase inhibitors is done so that like this can be arrested like that. So if you have McCune-Albright syndrome, we should give aromatase inhibitors. So then first testosterone can be given, second and the third generation anastrozole, and then letrozole. They are also available and they can be given if there is McCune-Albright syndrome. In cases of secondary central precocious puberty, like if she has been given steroid for long period of time because she had this McCune-Albright syndrome, and or she has like this congenital adrenal hyperplasia and she was receiving plenty of these steroids, then again she can have secondary central precocious puberty. Why? Because of the plenty of steroid hormones with, so you started treatment of the peripheral precocious puberty and the end result was that she developed this central precocious puberty. Other drugs which are used in the treatment of peripheral precocious puberty, these are progestational agents, for example medroxyprogesterone acetate. The mode of action is that it causes suppression of gonadotropin release and block gonadal steroidogenesis. Selective estrogen receptor modulators like tamoxifen, they cause estrogen receptor blockade. So receptor has been blocked, so even if there is
Laura,
FSH, nothing will happen,
this
the
all for
changes will not
question.
take place. Uh, then
Hmm.
antifungal agents, for example ketoconazole, they block enzymes in steroid biosynthesis. Then antiandrogens, they act by competing with the testosterone. These include like spironolactone and the cyproterone acetate. So they will block they will act, these anti-androgens, they act by competing with testosterone for its receptor in peripheral tissues. Cyproterone acetate, it has an additional progestational action at the pituitary level and which will partially suppress gonadotropin secretion. So that is about this treatment of peripheral precocious puberty. Now, like I mentioned before, that these girls they can have independent changes. Like maybe she will have only premature thalarch. So this is isolated premature breast development. It can be unilateral or bilateral, maybe occurring in the absence of other signs of puberty. So it is a benign condition and most commonly it is seen in young girls under the age of 2 years. Etiology is unclear, but it is thought to be due to episodic ovarian cyst formation and/or increased sensitivity of breast tissue to normal levels of the circulating estrogen. Growth velocity is normal and the bone age is not advanced. In most girls, puberty occurs at the usual time and the final height is normal and the fertility is 14% of the girls. Fertility can be normal, but 14% of the girls they will develop, those who develop precocious thalarch, they will develop into central precocious puberty. Started with the breast changes, but they are likely to go to full-fledged central precocious puberty. So, how we should manage? Because these are mild cases, so no need for investigations. And baseline serum gonadotropins and estradiol levels, they are within the normal pubertal range, and whereas the LHRH estimating, this is like it will show that FSH predominant response is there, and pelvic ultrasound it will demonstrate that uterine dimensions they are appropriate for the age and the normal ovarian morphology or the ovarian microcysts are there. How we should treat? Reassurance and careful follow-up every 6 months to assess growth and puberty to distinguish cases from those evolving into early central precocious puberty. Sometimes the girls they can have prepubertal vaginal bleeding, like it can be like isolated premature menarche, so it can be like very much disturbing for the family. So it warrants use careful evaluation. It is important not to diagnose premature menarche unless other causes of bleeding they have been excluded. What could be those causes? Exogenous administration of estrogen, vulvovaginitis, foreign body. Foreign body is the most common cause of discharge in the young girls. Okay. Then trauma,
Yes, this question.
yeah, urethral prolapse and sexual abuse they have been excluded. Sexual abuse is not the first thing to exclude. First thing is
Uh,
to exclude the foreign body. Okay, that is the most common cause of discharge in this age group. And then you need to exclude other um, tumors like that. What is that tumor? I told you last time also.
Type the tumor for this age.
Yeah, tumor for this age which will cause bleeding.
Yes,
Sarco
bleeding.
sarcoma
Yes,
botyoids.
granulosa.
That
Uh-huh.
is one thing, and sarcoma botyoids. They both can cause vaginal bleeding. Okay, and then rectal bleeding should be considered. Maybe this girl has like severe constipation and she has sustained some tear like that. Okay, maybe dysentery.
Mm.
So a careful history, onset, duration of bleeding, vaginal discharge, pubertal milestones, and examination like the general examination and the genital examination. So you need to inspect the external genitalia, introitus, urethra in the knee chest position. That is warranted in all cases to exclude significant pathology. If nothing is found, then EUA, an examination under anesthesia should be done, of course, by the consent of the parent and in the presence of the team. Chaperone should be there. It is warranted in cases of heavy vaginal bleeding or suspected vaginal trauma, foreign body or tumor, or in cases where bleeding continues despite negative findings on examination. Investigations to be considered include a full blood count, genital swabs, like if sexual abuse is suspected, then pelvic ultrasound, especially if examination is incomplete, urinalysis, full evaluation for precocious puberty, including an LH-RH test, is warranted in the presence of other signs of puberty. So, isolated premature menarche, it is defined as uterine bleeding occurring in young girls without other signs of secondary sexual development. No other sign of sexual development, but now she has this vaginal bleeds. So it means that she has increased sensitivity of the endometrium to the circulating estrogen levels, which are too low. Like the levels are very low and they cannot produce any changes in the breast development, and they can be the possible etiology. So no long-term sequelae they have been prescribed, and the condition usually resolves after 1 or 2 years. No treatment is necessary, but the child should be kept under follow-up. Premature or exaggerated adenarche or the pubarch. So isolated premature pubarch, it refers to the early appearance of the pubic hair prior to the 8 years of age in girls without any other pubertal change. The most common cause of this is exaggerated or the premature adenarche, which is the result of precocious secretion of androgens from the zona reticularis of the adrenal cortex. Additional features they may include axillary hair, adult body odors, spots, greasy hair and the skin and the mood swings, and increased growth velocity and slight advancement of the bone age that can also be observed. Although final height and the onset and progression of the puberty, these are not affected. In more severe cases, non-classical congenital adrenal hyperplasia, it must be ruled out by an adrenocorticotropin hormone stimulation test. Both prematurity and the small for gestation age, as well as overweight and the obesity, they have been associated with precocious puberty. In addition, excess weight gain in childhood, it may predispose to precocious puberty in susceptible individuals. The exact cause is unknown, but it is speculated that premature adenarche it is an early expression of the insulin resistance and isomers, and this is more common in obese children. Okay, so the appropriate age Therefore, for the definition of the precocious puberty, it remains controversial. But the consensus is that it is 8 for the girls and 9 for the boys. And the decision about whether to provide treatment is therefore often difficult, particularly for girls with the onset of puberty between the ages of 6 and 8 years. And the most appropriate age for stopping the treatment, it also remains uncertain. So just a recap, if you have to deal with a child with premature sexual development, you should take history and examination and see that she has thalarc and menarche or she has premature sexual hair development. If she has thalarc and menarche, you should assess growth velocity and the bone age. That is the first step. Okay. After, of course, after history and examination. Okay. This is in the investigations and assessment. If the girl has like rapid growth rate, then she will have advanced bone age. However, with which you are comparing the advanced bone age with the chronological age, like she is 8-year-old, but the bone age is 10 years. Okay, that is one thing. So the bone age is advanced. You will do FSH, LH, and the gonadotropin releasing hormone test. If the FSH, LH raises, and after this test, so it means that the girl has central precocious puberty. And we said that the ratio of the LH and FSH will be more than 1. LH will rise more than FSH. So it points towards central precocious puberty. So we should do cranial MRI. It can be normal, it can be abnormal. Then consider GnRH analog in selected cases, and if this cranial MRI is abnormal, then we don't know if there is tumor, if there is any infection, then it should be treated according to the etiology. Now going back to this point, the girl had the problem, she has advanced bone age, and you did this GnRH analog stimulation test. This test is negative. Why? Because the girl has low levels of the LH and FSH. So there is flat response, like the levels did not rise. So it means that this is peripheral precocious puberty. Okay, so then we should check the abdomen and the pelvis, do ultrasound. If they are normal, then we need to do assess for and remove exogenous estrogen source. So she's getting something. So the changes in the peripheral, they are due to different causes, but mostly the cause will be that estrogen level is high. So if you're not finding any cause in the body, like there is no harm, no tumor, nothing is producing this estrogen, then obviously it is coming from outside. So we need to exclude that thing which is coming from outside. So depending upon the etiology, we'll have to treat it. Now let's say we tested the bone age and it is advanced, and we see that, so if this is advanced, then we are following this line. Okay, so then we are going to see if we see the normal growth, like growth velocity and the bone age. If the growth rate is normal and bone age is not more than the chronological age, like she is 8-year-old and the bone age is also 8 years old, so it means that she has isolated this thalarc or she will have menarche. If she has thalarc, then we have to say that she has isolated premature thalarc, and then just reassure and offer observation. Reassurance and observation. Now there is another girl who has this menarche, so we will do pelvic ultrasound and in the prepubertal phase, and we will look at the other causes like foreign body and or the trauma. So if there is, then the diagnosis, if these have been excluded, then the diagnosis is isolated premature menarche, so reassurance and observation. Now in the other group, like there is premature sexual hair development. See, it is not thalarc or menarche, it is only hair development. So again, we are going to assess the growth velocity, see, look at the bone age, and measure serum androgen levels. If these both are normal or slightly increased growth velocity, bone age, and the serum androgens like slightly increased, then they can have isolated premature adenarche, and we are just going to reassure and observe them. Then if they have like rapid growth velocity, rapid, here it was like normal or slightly increased, but here it is too much increased. Okay, and she has advanced bone age, So we will look for 17-hydroxyprogesterone. If it is elevated, then we will make diagnosis of congenital adrenal hyperplasia. Congenital adrenal hyperplasia, you are going to treat with glucocorticoids and mineralocorticoid replacement. And if it is non-classical, then she will be treated with, if she has classical, treat with mineralocorticoid and glucocorticoid. And if it is non-classical congenital adrenal hyperplasia, then you will give only hydrocortisone. The second outcome can be like we are testing the girl and she has elevated level of the androgens like dehydroepiandrosterone. It is too much increase, 2 arrows. So it means that she has adrenal tumor. So if that adrenal tumor is there, you need to do the surgical treatment. That is all you need to remember about precocious puberty. Just remember it's a very important topic. In each exam you are getting like several questions from here. So pay attention to the causes. What are the ages? What are the changes? What is the sequence of events? What investigations should be done? How you will make a decision. So this decision making algorithm that is given in the end, that is very important for you. So we've spent some time on it. You should know about the etiologies, about the causes, and how to manage them. This is a very important topic for you. So give it some time. Thank you very much.